Okay, all right, the recording should be on now. Welcome back, everyone. Any questions or comments from previous lectures?
I appreciate it.
You were able to see it, huh? Yes, okay, so it really works. I think that's it's a very good mode because life happens. Of course, we all know that face-to-face is really the best learning experience, right? Because it's interactive and so forth. But life happens, like last-minute traffic and whatnot. So I leave it to your discretion. Obviously, it's expected that you be here, but then we have these other two availabilities. And even for review, even if you're here face-to-face, sometimes they shout a lot, and it's hard to take it all in. Yes, Laura, any of those are available because it does get so cold here, so feel free, all right? Feel free because I use it also for the other class that I teach on Saturday morning. It's 3.5 hours. That gets really cold. Deep freeze. All right. Okay, so welcome back again, and we continue with these bioethical issues at the beginning of human life. And I mean, frankly, we've jumped right into the frying pan here with controversial issues at the social level and, of course, at the personal and individual level too. But you see that they have a biological component to them, and then they have also a social component, and of course, a value system of each person. And they have a medical component to them, right? Because at the end of the day, these are procedures that are offered by the medical practice in the United States and many other countries, but we're focusing on the US today. And since you're aspired to be doctors, this is kind of preparing you for more to come in the medical school. So with that little introduction there, I'm going to minimize this little tile. We're going to look at the whole area of childbearing today, and to increment the possibilities of childbearing or to avoid childbearing in the United States with, again, in mind with the clinical practice, with the medical practice assisting that. And essentially two options, either contraception or natural family planning. So first I'm going to look at contraception and set some background to it, and then the bioethical analysis, and then we'll look at NFP also, first the biology, and then the bioethics, right? Keep in mind, I always like to start with the facts, and then we do a critical analysis of those facts. So if there are no other questions or comments, I'm moving forward. First, on contraception, they have the little handout. Oops, I forgot. So for the benefit of Chanel, let me do something for a moment here. Chanel, I'm just going to forward you the little handout, the outline handout that I'm using today. So I forgot, normally I send it with a link, and I forgot to do that. And it is this one. So let me just attach that. Whoops. Go back to the email, attach, where's attach? Oh, I have to respond first. Okay, there's a chat, give me a minute. That's probably Chanel. Okay, attach. Here we go. Just one page, front and back, and it's a simple outline. The PowerPoint will follow the outline anyway. So I just sent that. Now let me see the chat. Chat. Okay, you're welcome. So for contraception and non-therapeutic sterilization, okay, non-therapeutic sterilization, A functional definition is the avoidance of having children, all right? And it's intentional. Again, here the will is engaged. We're not talking about, infertility or something like that. We're talking about an intentional avoiding of having children during intercourse, of course. So from that perspective, actually contraception can be seen functionally as a type of sterilization. It's a chemical sterilization, right? And then I am putting here non-therapeutic sterilization because there's also a therapeutic sterilization that can happen. For example, a cancerous uterus. The standard practice, the protocol is to remove that uterus, right? A hysterectomy. So that's a therapeutic sterilization. The side effect is that that woman will become infertile, cannot carry a pregnancy actually, but that would be therapeutic. So here we are in non-therapeutic, which is also known at times as elective sterilization. Okay. And with regards to contraception then, they can be grouped into three categories. We're still looking first at the facts here, all right, the factual evidence. They're either mechanical or chemical or surgical means of contraception or sterilization. And we have the mechanical, the male or the female condoms, also cervical sponges or caps that typically have spermicides in them as a chemical, diaphragms and IUDs that we already talked about a little bit. Okay. These are mostly mechanical. They're trying to impede mechanically the fertilization process, in other words, for the sperm to fuse with the egg. And since there is a distance to travel for the sperm, then blocks can be used along the way. Also chemical, I'm sure we're very familiar, the estrogens and the progestins, either the pill or there's also a mini pill. Sometimes it has to do with dosage. There are also injectable dosages or subdermal patches that are long-term release. I think there's even one patch that is claiming like a 5-year infertility window. Okay, so there's a lot of research that has gone into this, obviously because there's a market for it. But there are several chemical ways of rendering the woman, typically it's on the woman, infertile. They pretty much focus on suppressing ovulation chemically. Okay. Surgically, again, because there are reproductive tracts that have actual organs to them and tubes and so forth. They focus mostly on the tubes to block the tube. All right, it's like if there's a highway and you cut the highway, then that impedes the traffic. So vasectomy for men on the vas deferens of the epididymis, I'm not exactly sure, but the tubes of the reproductive tract of men in the scrotum. For women, of course, tubal ligation, that's the fallopian tube. And again, for women, hysterectomy, which is the removal of part or all of the reproductive organs. I want to mention also that whereas, well, we'll get to effectiveness in a minute, but theoretically, these surgical procedures, well, the first two are reversible, theoretically. But then in practice, you actually have to see it's a patient by patient, right? Because it involves anastomosis, for example, you know, anastomosis, all right, is the sewing back of these tubes after they've been cut and tied or clamped and so forth. So that surgery is rather delicate. It's not, sometimes it's not 100%. There could be some side effects of that, like scarring, typically much more important in the woman, because scarring can then act as a roadblock if fertilization has happened and there's some scarring on the tube. That little embryo can get stuck there, and what do we have? We end up with an ectopic pregnancy, very high risk, okay? So in theory, they are reversible, but in practice, statistically, most men and women who have undergone either vasectomy or tubal ligation don't reverse it, all right? There's also fiscal considerations, in other words, cost money, they are painful, and so forth. So I'm just stating what actually happens on the ground, if you will, with these surgeries. Also, I want to point out, well, this goes to the next one, the effectiveness. Overall, there's a claim between 97 to 99% globally. So if we keep this figure in mind, 97 to 99%, we can make distinctions if you want. What's your intuition? Which are the least effective of these three methods? Could they be ranked? Mechanical, chemical, surgical, rank as to their effectiveness. I would say, I'm going to give you a hint that they're ranked, meaning from the least effective to the most effective overall. So generally, mechanical means overall are less effective than chemical means, and chemical means are less effective than surgical means. You see, it's getting more radical also, right? One thing is wearing a condom, another thing is taking a pill every day, and another thing is going for surgery. There's higher degrees of risk, cost, time, recovery, et cetera, et cetera. Okay, so the expectation is that, of course, there's a greater effectiveness through them for the overall investment of time, money, and energy, and so forth. But this is all assuming also that 97 to 99% range globally is also assuming perfect and consistent use, all right? Which, again, we can interpret that, going back, meaning, for example, the condoms, the caps, and the diaphragms, using them consistently before there is actual skin-to-skin contact. Okay, and this is in the literature. You can go online and go further into this. But once there is some degree of arousal between the man and the woman, typically the man is already beginning to secrete some semen that starts leaking, and it's also part of the lubrication at the biological level of the act, all right? And there is sperm in that semen and in that lubrication. And so if there's already skin-to-skin contact, there is already some percentage of probability of the woman getting pregnant if, of course, she's ovulating. If she's not ovulating, you can have 100 million sperm looking around all over the place and there's no egg to fertilize, okay? So, but then there is, again, the window is an expanded window because in the female tract, the human sperm lasts up to 5 days, all right? And so there is that 5-day window that one has to consider. She could have ovulated 5 days later, up to 5 days later. Okay, so all these are things to consider when we say, oh no, I'm using a condom or she's on the pill. Yes, but, okay? Yes, but. All right, so for chemical, the same. I've talked about it. The typical issue here, and these are mostly on the woman, they're ovulation suppressants, all right? Essentially higher dosage of estrogens or progesterone to suppress ovulation. But then there is breakthrough ovulation, which is documented, all right? So there's kind of an insistence. That's another thing. Nature is economic, I mentioned. Nature is also tenacious, okay? It's kind of fixated. If nature wants to do something, it's kind of hardwired to do that. And if an egg, on average, is supposed to mature every month, the body is going to try to do everything possible to get that done. Because in the big picture, and this is not exclusive to the human, in the big picture, what's at stake there is the progeny, the perpetuation of the species, all right? So these are forces, if you will, that are there at a very sophisticated biochemical level, that us coming in with some single or a couple of hormones thinking that we're going to suppress an event that is being perfected, if you will, by evolution over millions of years, right? We have to have a little humility on the medical side, okay? All right, and then surgery, even, I don't know if you've heard of cases, but it's documented that somehow, sometimes sperm get to jump that gap, all right, whether there's clamps, cutting, or whatever, and do fertilize the egg. And sometimes that fertilized egg, which is now a zygote or a blastocyst, all right, it's an early embryo, can also jump back that gap and either get back into the uterus or even sometimes extrauterine pregnancies, all right, abdominal pregnancies, some of which have been carried to viability. And with surgery, then that baby is going to be rushed to the NICU, the neonatal intensive care unit, and some have actually lived. And they adhered ex utero in the abdominal region. Typically, they go for the intestines or some other organ that is rich in nutrients with highly vascularization, but super high risk. But again, it's documented. You can look it up, extrauterine pregnancies. Interesting. The body is also very dynamic, adaptable. Another principle of nature. There was a ding here. Let me see what's going on. Okay. Just looking, all's quiet on the chat front, so I presume people are slugging in and out, I don't know, but okay. All right, you can always call us by phone, all right, if you need to ask a question and the chat is not working, whatever. So, this 97 to 99%, okay, and that's in the literature of these products. You can look it up. Typically, it's a large page like this. I don't know if you've seen, I always forget to bring a little sheet from the pill box that is a piece of paper like this with print front and back, and the font is like 6 points or something like that, right? Tiny print of all the stuff that can go wrong, because this is also a legal thing, and they're trying to cover themselves, but no one will ever claim 100%, because they just can't, all right? Again, keep in mind that medicine is a statistical art and science, and that means that with perfect, consistent use every day on the clock for years, 1 to 3% of women will get pregnant using any one of these or combination of methods, all right?
100% can be achieved with removal of the organ.
Well, which organ?
Like the uterus.
The uterus in the case of the woman, yes. Or the actual reproductive organs, the primary reproductive organs, the glands themselves that produce, the ovary. If you remove the ovaries, both ovaries and both testicles, then there ain't going to be any gametes around, right, to be fertilized. So yeah, that's castration, or that's an ovarian sterilization. Yes, right. Okay, so you see this percentage is real, it's in the literature, and therefore there's not 100% here unless, like Eric said, the actual glands are removed. Risk, again, it's in the literature. I focus mostly on, this is chemical contraceptives, the pill, which is the most widely used contraceptive, not only in the United States, and at least in the Northwestern Hemisphere, where we have more access to medication and pills. All right, so blood clots is a big one. Various types of cancers. You're fully around with the hormonal level. All right, that has impact on the body. High blood pressure, depression at the psychological level, other issues. These are the main ones. As far as side effects while in use, all right, aside from the risk, side effects to greater or lesser extent on women, and which can be adjusted by age and other factors. nausea, vomiting, dizziness, headaches, vaginal infections, abdominal pain, irregular bleeding, diminished libido. Interesting, diminished libido, yeah, because we know, and we'll see in NFP, that naturally, when the woman is ovulating, there's a higher level of estrogen, which is stimulating the brain centers for libido, which is a psychological term for sexual desire, and it's a natural thing. Weight gain, retaining mostly water or other fluids, right? The acne can shift around, especially on the youth. Appetite changes of mood, tenderness of the breast, again related to setting up for lactation, in preparation for lactation. If there is ovulation, the expectation is that there will be fertilization, and therefore preparing for lactation. That's all part of the complexity of the cycle, of the woman's cycle. Body hair is a secondary, we know it's a secondary characteristic, sexual characteristic in men and women. Discharge, bone density, so osteoporosis, premature osteoporosis, possibly. We know that bone density loss is more significant in women than in men. Again, because of menstruation, it seems to lose a significant amount of calcium there. All right, and so that's an issue. We know that menopausic women are encouraged to go on a calcium supplement, right? And ectopic pregnancy, which again is a high-risk issue for the mom and certainly for the embryo. Okay. Now let's go more into the bioethical analysis of this, the critical analysis. I've just given you an overall view of the physical, biological issues involved. From a clinical perspective, because to this day, it's odd to me in my mind from the outside, not being a clinician, that, for example, Plan B can be sought over the counter, but contraceptives still need prescription. Okay, and yet Plan B is kind of a super aggressive type of contraception that's going on at the chemical level. But anyway, it still needs a prescription, and therefore it involves the medical practice, right? First principle of medicine: do no harm. Do no harm. We have to understand this do no harm, which is age-old covenant, if you will, of medicine, which, by the way, this justifies medicine, because think about it for a moment, a little philosophically, and looking at natural selection, you understand that the practice of medicine goes diametrically opposed to natural selection, right? Because what does medicine do? The practice of medicine is enabling the weaker at least to reach reproductive age and beyond, which is against natural selection, because in nature, no other species practice medicine, for example. Okay. And all other species are doing fine, and really, in general, are getting more and more robust as they speciate and as they adapt to the environment. But the human species, by the practice of medicine overall, is weakening, if you will, the gene pool in the human population, because weaker people, biologically speaking, which would have died or not been able to procreate through the practice of medicine, are procreating, okay? And they're passing on those weaker genes one way or another. Even if it's an issue that is not related to sexuality, it could be an issue with the heart, it could be the lungs, any other organ system of the body, right? Follow? So the practice of medicine really goes 180 degrees against natural selection. However, we are not going to stop the practice of medicine, right? We're going to we want to increase it and make it more and more available for a greater number of people in the world. So certainly, how do we justify that? If with the practice of medicine, we're weakening the human population as a whole.
Can we extend it to vaccinations?
Yes, absolutely. That's one subset, if you will, which is very clear, particularly in what we call the developing world, which generally correlates with the Southern Hemisphere, but also going to some Asian areas, okay? They have less access to medicine, they're more susceptible to epidemics or pandemics, and therefore vaccination is critical in those areas and so forth. We've just seen, I mean, not a week goes by, right? Yeah, Dr. Chaffee, not a week goes by. Just this week, it was in the news of Ebola rising again in some parts of Africa. Very scary. I mean, that thing is lethal. So how do we justify the practice of medicine? And do no harm is a corollary to that. Benevolence, okay? This is what we call virtuous ethics, which is certainly pre-Christian. It goes back to classical Greece, which people sustained, the scholars sustained, the ones who study culture and the development of culture over millennia, sustained that really Western culture is, the foundations of Western culture is in classical Greece, at least the philosophical and intellectual foundations, and also mathematical, physics, many scientists, even the natural sciences, okay, with Aristotle, Plato, all those people. Agriculturally, it could be the Middle East, what is known as the Fertile Crescent, where it is precisely the Tigris and the Euphrates, Iraq and Iran today. That's agriculturally. But intellectually, classical Greece is the foundation of our Western culture. And also the development of medicine. In fact, Hippocrates, right? Hippocrates, the Hippocratic Oath from a Greek doctor. So how do we justify the practice of medicine? By the virtue of benevolence. We have the capacity to do the good. And benevolence then follows up with beneficence, right? Benevolence and beneficence. We have the capacity to do the good, therefore we should do the good, okay? And that's benevolence and beneficence. Let me do this and show some notes here, words. Put it in here. These are, let me just quickly to make a distinction. I'm using the notes just to put some extra, where am I gonna get the, okay. Let me select this for a moment. It's a work in progress, and then, oops, yeah. I'll just make them bold. Then hopefully I can type in between with regular font. And we're gonna save this as notes quickly. Right, so think about benevolence and beneficence. Again, the added value of this course is that you're learning a little Greek and Latin. What do I mean by benevolence? Bene volere, right? To desire the good. Bene, good. Volere, so that's why with all humility, if you have some Spanish background, it helps. And it will help you in all the medical terminology that you have to learn big time, because medicine. I still remember when I was studying at FIU in the 70s, I told you, I'm ancient, my biology degree, my bachelor's in biology, the 70s, way before the priesthood, on the shelf in the biology section of the library, I actually found a textbook of biology written in Latin. Okay, it was like from the 60s or something like, maybe 50s, I don't know, but you know, it's still fairly close. It was just a couple of decades away. And that's the standard language for centuries of medicine and science and many of the disciplines. So what did I say? Benevolence? Oh, it's going to come out. Okay, so under the beneficence. Let me check the spelling on this. I think it was SC, no, CC, okay, I got it right. Okay. So, bene volere, will, comes from voluntas, the will, and to do, to desire the good, right? We see someone, compassion, I mean, we see someone hurting, we go to the rescue. And we facere, beneficence. Ficence is, the root word of ficence is facere, which is to do. Hacer, facere, hacer. To do the good. We have the capacity to do the good, therefore we should do the good, right? And that's how we can talk about do no harm. Driving medicine for millennia to this day. Therefore, from that perspective, what is sterilization? What is sterilization doing? Whether it's mechanical, like a surgical sterilization, or a chemical, or mechanical, we can lump them as a type of sterilization, contraception, right? Is rendering a healthy organ inoperative, precisely because it's healthy. Okay? Now, I want to back up for a moment, do no harm. How to interpret do no harm in the proper way? Because let's say a appendicitis, okay? What's going on? First of all, it has nothing to do with reproduction, right? Okay. But the child is showing symptoms of appendicitis, sharp pain on the side and so forth, okay? Rush them to the hospital. They do the diagnostic, sure enough, where does he go? Where does that child go? Surgery, okay? Emergency surgery, what are they gonna do? Well, maybe they can do laparoscopy. I think now they can do laparoscopic, right? I think, but traditionally, gotta open them up and excise an appendectomy. Okay, well, that's certainly doing some harm, right? Surgery, opening up the fellow and exposing to risk and so forth. So they're doing harm. I mean, the scalpel, or even the Da Vinci, what's the Da Vinci? You know Da Vinci? No? Oh, that's your friend. That's robotic surgery. That's the laparoscopic surgery, all right? So machine looks like an octopus. It's all sterilized, and they go in and they create a dome inside, generate with CO2, generate a dome in the abdomen, and then go to town and all kinds of surgeries. And the screen, no, it's even safer, not necessarily faster, but it's safer than traditional surgery because you don't depend on the hand of the surgeon. The instrument is more accurate. The first thing that happens is that the screen is magnified anywhere from 2 to 10 times larger. All right, so stuff that is very small is all of a sudden large, and the surgeon is just playing with a joystick on the controls. And so, very interesting, all this robotic surgery that's going on today. But we have to understand do no harm in the big picture. Certainly, there's going to be local, immediate, localized harm successively to get to that inflamed appendix before it ruptures. But the overall is a greater good of saving the life of the person so that they don't get into sepsis or whatever. And therefore, the do no harm is in the global picture, all right? It's like saying, I'm eating. Well, am I having the soup? Am I having the main course or the dessert? Well, I'm eating, all right, which involves the entire thing. So the do no harm is in the big picture. You can say, well, why can't we apply then do no harm to contraception or sterilization, non-therapeutic sterilization, right? Why can't we apply that principle there too? Do no harm, because it's for the good of the woman who doesn't want to get pregnant, right? Well, because the action and the consequence, physiologically, it's all bad. You know, with appendectomy or any other kind of surgery or therapy, the end result physiologically is good. Follow? But here, the end result is rendering a healthy organ inoperative. In fact, if those reproductive organs were not healthy, okay, then this procedure would not be done. And that's the proof that it's counter to do no harm. Because if those organs were inoperative, the proper medical procedure would be what? To try to render them operative. For instance, precisely scarring, right? To go in and try to correct that. So that's why truly we can look at these procedures as bad medicine, because they're rendering healthy organs inoperative. You would even think that this kind of procedure, it's legal exposure, but it's not. It's not, for some kind of quirk of the interpreter of jurisprudence, but certainly when it's done involuntarily, it's suable, at least in our country. In other countries, all kinds of stuff happens. But even when it's voluntary, a person seeking to render their healthy organs inoperative should be counseled to the contrary, right? Should be counseled, it's not good for your health. And again, considering if these procedures had zero side effects or risks, and some of these are quite serious, right? To the point that some women are not indicated for the pill, for example. They're just too high risk. All right?
Isn't that, because I think you did the sex change thing in the presentation?
Oh, that was
Yeah, okay, for sex change?
Yeah, because there's something similar, like if an individual seeks to have a
transition,
surgery, so that can be considered harmful because it's changing the
Indeed.
genetically programmed.
Indeed, and we have time. We'll look at transgenderism in one of the lectures toward the end. We have to build up some background first, but yes, very controversial today and explosive, all right, including with legal protection. But keep in mind that legal protection or legality doesn't necessarily mean morality. Give an example. I mean, adultery, normal people will consider adultery immoral. And it's not illegal. When's the last time you saw someone get arrested for adultery? Okay? Or lying, even lying. Lying really is not an ethical thing to do. And yet, people lie all the time. And unless they're under oath, as in a court for perjury, then yes. But that's really a very small subset of lying, which tragically happens all the time. But it's not an ethical thing to do. And it's not a professional standard, for example. Imagine a doctor lying to a patient. That is, absolutely a no-no. And yet, and in that profession, that could actually be exposure, legal exposure, all right? But so we have to keep in mind that things that are not necessarily, law cannot cover everything. The positive law cannot cover. There's another law that's behind positive law, okay, which is natural law. And even for believers, there's another, and even for non-believers, with all due respect, there's another law behind natural law, which is divine law. Okay? So that sequence is essential, and I'll tell you folks, you can look it up. It's the history of this country. The founding fathers of the nation, including the ones who put on the Constitution and everything else, and the protections that we have under the law, were all natural law believers. In other words, as they were crafting the laws of this nation and the Constitution and the Bill of Rights and all that, they were really, truly, honestly inspired by natural law. In other words, nature. Okay, what is natural? What is natural is to protect the humans and so forth. So I offer that as another background, if you will, that will be questioned today because we live in a positivistic society. Positivistic means it's a legalistic mentality. As long as it's not illegal, you have your opinion and I have mine, but please step aside because it's not illegal. If you think it's so bad, make it illegal, but then we go berserk trying to already, cops will tell you, any one of us driving through the streets of Miami will break 12 to 24 laws, traffic laws every day without even realizing it, okay? The stop sign is the most famous one, but it could be many, many others because it's a huge volume of laws. Some are high impact, some are very low impact, but we cannot really legislate on every single behavior of the human, okay? So we have to appeal at some point to a mature conscience and right behavior, proper behavior. So that's why I'm saying, really, I mean, if we're honest about this, contraception, non-therapeutic sterilization is bad medicine. It's not good for that patient. This is different from therapeutic sterilization. When we're talking about a serious medical condition that can be corrected precisely with a hysterectomy, or, I mean, there's also cancer of the testicles, all right, which the indication is castration. So this adjective, therapeutic or non-therapeutic sterilization, makes a difference, bioethically speaking, all right? Now, and this is also predicated on a couple other columns, if you will, or presuppositions. Number one is that these procedures, contraception or sterilization, whether mechanical, chemical, or surgical, have side effects and contraindications, some of which are serious, some are lighter. Number one. Number two, at the end of the day, there are alternatives. There's one big alternative, which is healthy, and it's nature's way, all right? And that's natural family planning. So stop for a moment to see if there are any questions or comments before we move forward to NFP.
Can you speak about the rape case?
Right, okay, so we can look at rape, the case of rape and or incest, which also, I mean, that's the silent reality there, where the most often case statistically of rape or incest is in the home. It's the father with his daughters, okay, and maybe less in the US, but it's not reported, it's not detected, it's not, there's a lot of issues going on there, psychologically and sociologically, but these are very serious issues that we need to address as soon as I look at the chat for a moment. Okay, thanks, no questions from Chanel, okay. So yes, rape and incest. These are very, very serious issues. They have to be taken, they have to be encouraged to seek clinical help right away. The sooner they seek medical help, the better they can be helped, all right? There's a lot of guilt and shame involved in it. Even the definition of, let's stick with rape, can be fuzzy. The boundary can be fuzzy because what's consensual and what's non-consensual, right? It can be that there was a lead-on, and I'm speaking to adults here. There could have been a lead-on, but she wasn't realizing the implications of that leading on, and he took it for something that was different and went all the way, and then was that rape or not? Who knows, okay? But there's the communication there can be tricky at times and can be mixed signals and everything else. But they take what we say bona fide rapes when she actually did not want intercourse and was forced. All right. And so we have now a person who is a patient because she's going to need help physically and psychologically. Is very traumatizing. The sooner we can get that person to a clinical setting, the better off she will be, all right? But many times she's so embarrassed, she's afraid, she's hurt, she just wants to crawl under the rug, like they say. And if you ever know of someone or hear of someone through the grapevine, try to encourage that person immediately to go and get, first of all, if she's not ovulating, then she can actually be given the plan V to try to prevent the consequence of the aggression at the sperm level, because the sperm can be seen, again, bioethically as a continuation of the act of aggression, all right? And so in that case, it's not truly a contraception, it is preventing conception, but it's a justified prevention of the conception. All right, which is the mega dose of estrogen to try to suppress ovulation if she's not ovulating. If she is or has ovulated in that window of the 24 hours to 48 hours, more or less, of the rape, and she has ovulated, then it's a different story because we now may have already an embryo, early embryo forming and traveling to the uterus, And we know that this megadosage will also render the endometrium hostile to implantation. And so now this treatment, which was intended to be contraceptive, is no longer contraceptive because fertilization has already occurred, and now it's going to be an abortifacient. So again, we would have to take issue with that, all right? So what's the clinical setting? What is actually the protocol? Well, it's mostly in Catholic hospitals, this protocol is they have to assess somehow, at intake, they have to assess if the woman has ovulated or not. So you can start with a urine test, and if it does give positive, you can follow up with a blood test, which would be much more precise, correct? And then you go from there.
I know it's like much debate of eliminating abortions, and I was thinking like if that happens, there's going to be an increase in rape cases. Like, you know, women will still elect to have abortions, so
yes,
I'm pretty sure they would just go to the doctor and say, "Yeah, I was raped. I was raped. I was raped." So the number of cases.
Yes, exactly, and that's the wisdom of the person doing the intake, is to get what is known as her social history. Aside from her medical history and her menstruation history, for example, you know, her cycling and all this, also what they call the social history, which would be, goes more on the behavioral side, all right, that try to ascertain what's going on. It's a free country, abortion is legal, so even she can claim whatever she wants to claim, all right, but at least the medical staff has to be professional about it and has to have her best interest in mind. But if there is pregnancy, then frankly, there's two interests. There's another little tiny patient in there, okay, which will be radically affected by the decision that is taken either way. Now, keep in mind that if she is ovulating, you know, having her go through an abortion, even an early abortion like this, is not going to reverse the rape, because the rape has happened already, okay? So we have to deal with that, and we have to consider in the complexity of that dynamic, that later on, let's say that this is a woman that is generally against abortion, all right? And she doesn't really, I mean, she understands that life begins at fertilization, at conception, and she's not for abortion, okay? And she got raped. And now she happened to be ovulating, and she could be now conceiving, and she goes through the procedure and has that early abortion. Later on, that could be like a second trauma on top of the rape. Now, to realize that seeking the help and just being put through a utilitarian protocol, which automatically does, even don't worry about the testing, just automatically do the plan B, all right? She was the recipient of bad medicine because she was not respected in her pro-life views, and now she has the second trauma of having, having undergone a procedure that killed her child. And so this is a very, very delicate issue that has to, respect is foremost. The person has to be treated with competence, professionalism, but care, and also consider that possibly there's another human being involved there, okay? Very early on, but true, which is what I tried to set up for the last 3 lectures. So rape is very delicate. There's also psychological factors involved here, because sometimes us from the outside see it, we tend to see it simplistically. Certainly for men, you know, it's a theoretical case, okay? But I can tell you that, again, it's in the literature. What is the fertility rate in the United States right now? What is fertility rate, first of all? Okay, every nation has a fertility rate. More or less, globally, more or less, okay, it's the percentage of women in the reproductive years, right, who are actually pregnant right now in the United States. Well, it could be, yeah, well, it's not the birth rate, okay?
Yeah, that's birth.
Yeah, it's not the birth rate.
But if you're using contraception,
mm-hmm.
you're not actually, or not or at least most of the cases do not ovulate. I mean,
Right.
it could be right through ovulation.
It could be, but she's still in her fertile years, okay? So we look at, let's say globally again, for keeping the arithmetic simple, from 10 to 50 years of age, all right, those 40 years. So all the women, the subset of women in the United States, first of all, how many people in the United States? We'll start with some numbers, just for the sake of it. It's about 320 million, I think, or something like that, 310 million. Let's round it up to 300 million, all right? Of those, how many are women? Well, what's the percentage, more or less, from nature? About 50% globally. It's a little bit more. I think it's about 51% women and 49% men. That has to do with other factors. Women tend to live a little longer and so forth because we're looking at overall, it's a big, big picture of numbers in the United States. Okay, so more or less 150 million Americans or people living in the United States are women. Not all of them are between 10 and 40 years of age, right? Many of them are younger, many of them are older. So there's a set, I don't really know what number that is, but it's a percentage, 150 million, I would expect that it's in the millions. But those are the women in reproductive age in the United States today, okay? So that would be the denominator on the equation. What's the numerator? Of that, let's say that it's, let's round it off to 10 million to make it simple, okay? 10 million women are in reproductive age today in the United States. It sounds like a low number, but let's keep it there. How many are actually pregnant today? Okay, anywhere in the 9 months that they know, because some will not know. Maybe they're just a week or a day pregnant. They don't know. Maybe they're 2-3 weeks pregnant. All right. So I'm about to give birth. Oops, they just did. Well, they just fell off. It's a dynamic system. But let's say just kind of freeze the population for a moment. How many are pregnant right now? Let's say that it's 1 million. It sounds like a high number. Okay. Well, so what's the equation? What's the fraction? 1/10. Of 10 million women in the United States who are in reproductive age right now, 1 million is actually pregnant. What's the percentage there? So translate a fraction to a percentage or a decimal, 10%. That's actually the number. It's about 11%. At least when I researched it, it was 2-3 years ago, I think, but it's about 11%. It's a little longer. It's about 10 years that I looked at that number. But it's about 11%. That's the fertility rate of the nation. Okay, and so for cases of rape, I don't know what the bill was, but I think when there's a chat, I'm most concerned. Chanel, if you have a question, either call or text. Jody, I think, has your number, all right? Appreciate it. All right, so that would be like the base fertility rate for the United States right now. And let's keep it simple, 10%. Cases of rape. How many people become pregnant? How many women become pregnant from a rape? Again, it's kind of a fuzzy statistics. It depends on how you're counting those numbers and what you are actually considering a rape. We spoke about that. But it's anywhere from what I've seen from 0.1 to 5%. 5% is way on the high side, okay? Is given a lot of claims the blanket benefit of the doubt. Because, you know, they're even, I mean, you can think of Stormy and Trump right now, which are popular cases in the news. There's millions involved there, right? So there can be motivations either way. But let's take the high number of 5%. That is half of the natural fertility rate in the United States right now. Is that statistically significant or not? That's a statistical question. That's very significant statistically, you know, half, all right? Let's say you either have $100 or $50. Is that significant? Yeah, that's pretty significant. Okay, at least for me anyways, it makes a difference. So, and that's the best number, if you will, or the highest number of fertility of fertilization in cases of rape. All right, what is that saying? you know, women who are getting raped and getting pregnant are obviously within those 10 million women, right? They're in the reproductive age, otherwise they couldn't get pregnant. So on average, they should be getting pregnant, what, 10 or 11% of the time. They're getting pregnant 5% of the time. How do we account for that? And it's not that all these subset of women, all right, happen to be infertile or happen to have reproductive issues, okay, or that the man was infertile or incompetent sperm or so forth. No, because these are statistics in the millions. So those tails are very narrow. What is the other factor? If it's not physiological,
Contraception? Is it because they're on that? That's
well, yeah, she could, good. She could be on contraceptives, all right. But there's another one, because even if we sector out, these studies have been done, and if they sector out the population of women who were raped, who were on contraception, all right, obviously we would expect them not to get pregnant. But others are not. There's another one I'm trying to get at is that there are psychological factors. There are psychological factors that just as the woman herself is repelling that aggressor, all right, that unjust aggressor, her body, her chemistry is also repelling the products of that aggressor, which is the sperm. So at the moment, within minutes and seconds, her body is producing chemicals that is trying to repel that sperm from fertilizing. It's amazing. That's how complicated the system is, but real. Okay, and the stats are there to prove it. So, and the only explanation is the psychological, not one in it that has a hormonal effect and has a physiological effect, has a biochemical effect. All right. Okay, so these are very delicate issues. But the bottom line, at least from the clinical perspective and from good medicine, to do no harm, is to try to get that woman in a clinical setting as soon as possible. And hopefully that clinical setting would not be utilitarian, which sadly is the majority of them, and will consider, at least raise the issue, well, if you are pregnant, what do you want to do? Before they just give her the dosage automatic. Okay?
I think even though we speak a lot about humans, the argument extends to dogs as well, because of the practice of castrating,
neutering, and right.
Yeah, so the dogs that are non-thoroughbreds, like, the shelters,
it's automatic. Yeah, so, pretty much. Yeah.
But that's a viable organism. So
correct. I know. The only thing is that we make a difference between a human and a non-human, in the sense that what is licit to do in animals may not be licit to do in humans. For example, eating them. Okay, I mean, we're omnivores by the formation of our teeth, which means that we also eat meat, and that meat comes from animals that were killed. Now they're supposed to be killed humanely, but at the end of the day, they're killed, all right? And we don't go around killing people for cannibalism, so there's a difference there. And in fact, even in the practice of medicine, there is a distinction. You either become an MD or you become a vet, okay? But it could be seen, neutering and spading could be seen as good medical practice for the sake, because they don't know. The animals, they certainly don't have the will to engage, and they're gonna have to live by instinct. One time it was late at night, I pulled into Pollo Tropical, all right, the parking lot in the back, and it was dark, and the trash containers were out there at the back of the parking lot. And that parking lot, as I turned out, was dark because it was after hours. As my headlights, the car headlights, flooded the parking lot, it was full of cats. It was jam-packed full of cats, okay? Just licking their chops from Pollo Tropical excess. So, I mean, they do cut down on the mouse population in town, but they have issues of their own, right? So, veterinary has its own bioethics. Okay. Okay, so let me move to NFP, because, look, we're into this time of nature, what's natural, what's healthy, and so forth. So Up until now, I have yet to mention God, faith, or religion because I'm trying to use the arguments of nature precisely. And that's why natural is part of NFP. Bless you. Okay. Let's focus then on the biology of NFP first, which essentially is detecting ovulation, seeking to determine the time of ovulation when the woman is ovulating. All right. So right away, I have to say that this is not the rhythm, because the rhythm is not based on ovulation, it's based on another symptom, which is what? The rhythm, or la regla, is measuring menstruation, okay, which is discarding an over-ripened egg, which is biologically just taking out the garbage. In other words, that egg, after the 24-hour window, on average, has become over-ripened and now has to be discarded. Okay, this is standard for mammals, humans included. And so when it's discarded, also the lining of the uterus is shed because it became spongy in the expectation of an implantation, which didn't happen. So now that has to be sloughed off and shed, and that's the menstruation. Now, that menstruation is not as accurate as the ovulation itself, because when that happens will vary from woman to woman, from age to age, even from mood to mood can change it. So a simple analogy that I use is for dinner. You know, when you throw out the garbage from the dinner, can be immediately after the dinner, or even washing the dishes, or it can be the following day. It depends. Okay, there are different options and preferences, but what's the important event? The important event is actually the dinner. All right. And so the same here. The important event physiologically, beginning with that, is the ovulation, preparing for fertilization for a new child. So the ovulation symptoms, because they have been selected on for millennia, are pretty precise and specific, and they are at least 10 in the woman, 3 of which are considered primary, and the other 7 secondary symptoms. So quickly, let's go through them. The primary ones, the basal body temperature. What is the BBT of the average body, which is probably being affected right now in this room by the cold environment? Exactly, 98.6 what? Fahrenheit. Put a unit to it because centigrades is very different, right? That would be close to boiling point in centigrade. So what does that translate to the decimal system? 37. 37 centigrade. Okay, 37. So you should know that equivalency, the 5/8 times 32, whatever that is, or plus 32 equation. But that's the basal body temperature, which is one of the 3 symptoms. What happens with the BBT during ovulation? Increases slightly. Okay. So then we can ask about how much? About 1 degree maximum, kind of 1 degree Fahrenheit. So it's not a big deal. All right. It's not even temperature, it's not considered a temperance or a temperature. All right. But increases slightly during ovulation and during the follicle, the rupture of the follicle. So, but that can be measured, especially long term when there's a pattern. But it should be measured at rest, because as soon as we get up in the morning and we're moving about, our basal body temperature is going to fluctuate back and forth. And certainly 1 to 2 degrees is normal range of fluctuation. Okay, I mean, temperature, the child running a temperature, what? Beginning at 99 point something, getting close to 100. So you have 1 to 1.5 degree range of normality of the 98.6. And this ovulation symptom is going to be within that range, okay? So it has to be tracked typically when the body is at rest, which would be normally before waking up in the morning or before rising. So what they say is, well, if you're going to follow this symptom around 5 p.m., just to choose a number, 5 a.m., set the alarm, take the thermometer, take the temperature. These digital thermometers, which can can get to the centesimal in Fahrenheit, okay? Digitals will stay recorded in the memory. Take the temperature, half asleep, set the temperature, set the thermometer down, continue your sleep until you get up later, and then record that temperature on a chart, Excel, whatever, and then track it month after month, day after day, and to look at the peak. If the woman is running a temperature, maybe she has a low-grade infection or something, then that's going to vary also and complicate the signal, right, the symptom. So of these three, the least reliable is the BPT, but it's still considered primary because it's associated simply with the rupture of the follicle, physiologically. Next is the activity of the cervix itself. As you know, cervix is a circular muscle. Therefore, it's an involuntary muscle. What are these circular muscles called in the body? Generally, sphincters. Their function is to open and close, right? And starting with the mouth, sphincter, all the way down the esophagus, stomach, the pylorus, the other one, controlling in and out of the stomach, digestive tract, all the intestines, peristaltic motion and all that, all the way down to the last one, which is the anus, is the other sphincter, and also in the reproductive tract. So the sphincter, the cervix, which is like a little cone, that will have its own activity, so that during because it's an opening to the internal organs of the woman, then during non-ovulation, all right, during the infertile period, that sphincter is closed, shut, tight, and typically high, and even goes off center a little bit. You can see photos of this. You can get online and look at all these medical photos that are there. Very interesting. Tight, high, and off center. Okay? Because that opening is to the internal organs, which could become infected. During ovulation, that little cone, that little sphincter cervix will drop a little, become soft, and dilate somewhat, and centralize to kind of match up truly with the head of the penis to try to receive as much semen as possible, because that's what the sperm is. So it's all physiological, and it's design. It's an elegant design that is done this way. All right. So that's during ovulation. That symptom can be detected by the woman with a touch, a tact, typically the middle finger or the index. Make sure it's a hygiene thing. Make sure that the hands have to be clean, all right? But the activity of the cervix can be detected by the woman on a daily basis to see what the cervix is doing, and she can also track that. In fact, there are things that you can pull down from the internet charts, which are preset, and you can choose all the different types of activities shown on the chart that can be tracked, all right? However, the mucus of these three primary symptoms is the most accurate one, because the cervical mucus, now you're getting down to the biochemical level. And again, very quickly, the cervical mucus does several things. First of all, it lines up the entire reproductive tract of the woman, all the fallopian tubes, all the way down through the uterus, out the cervix, and into the vagina. And when the woman is infertile, when the woman is not ovulating, which is most of the time, 3/4 of the time, with regards to a month, 3 weeks on average out of the month, that cervical mucus serves as a roadblock, as a cap, as a plug. It's actually called a plug, cervical plug. All right, because microscopically it looks like a mesh. So they're long proteins, they're polycarboproteins and carbohydrates that are long fibers. And during the infertile period, it has something to do with pH and other chemical factors. They bunch up into a mesh, as if a fishing line that gets tangled up, all right, it forms like a wad. That's at the microscopic level, and that's a cervical plug that is naturally done by the mucus. And it's also known as tacky and opaque, and it's not elastic. All right. As the woman is examining the activity of her cervix, she can also pick up some of the mucus and then do this check between the middle finger and the thumb to see what is the quality of that mucus with regards to color and elasticity mostly. On the opposite end, when she's actually ovulating, that mucus becomes a highway for the sperm microscopically to travel through. And so those fibers elongate, all right? And that can be detected visually, and it becomes, let's say, like an egg white, uncooked, the white of an egg, of a chicken egg, all right? Not the yolk, but what we call the white of the egg, when it's transparent before cooking. You look at that kind of consistency, it's runny and elastic and clear. Those are the typical characteristics of the cervical mucus when she's ovulating. And so that's a very, very distinct, clear signal that is there. With time and experience, the woman can detect her time of ovulation. Then the other 7, I don't have time to, I always run out of time, I'm so sorry. Mittelschmerz, it's a German word. It means Schmerz is pain in the middle. When the woman feels a little pain on the side, that's actually the fallopian, the infundibulum of the fallopian tubes moving toward the ovaries physically to get close to catch that egg as it's rupturing from the follicle, and it's causing a little pain. It's on the other side of the days from menstruation. Okay, so this is not menstrual pain. This is the 2 weeks away from it. This is during ovulation itself. Some spotting also, the swollen organs because of fluid retention, the increased desire for sexual activity, the tenderness in preparation for lactation in case there is pregnancy and development and so forth, general retention of water. Ferning is something that happens actually with the excess estrogen, even in the saliva, that can be detected. There's a little ferning microscope that can be bought online, and a little dab of saliva will let it dry, and it will crystallize. And the crystallization pattern is called ferning because it looks more or less like a fern, like the frond of a fern, the leaf formation of ferns, all right, looks a little bit like that, all right. A tree-like formation is the crystallization of estrogen from saliva. It's called ferning. Anyway, these are the secondary symptoms, but of all of them, the cervical mucus is by far the most accurate one. These can be used for detecting ovulation, and therefore now the woman can decide in collaboration with the husband what they're going to do to either achieve conception, because NFP can also be used for people who are having, couples who are having difficulty conceiving. All right, they will concentrate during intimacy, sexual intimacy during her time of ovulation, or to avoid conception for justified reasons. They would have to abstain from intercourse specifically during her time of ovulation, which can be in the narrow window 24 hours, but in the bigger picture 5 days because of the sperm viability of the sperm inside the female tract. And then if you want to put 1 day of margin before and after, that makes it a nice week, if you will, out of the 4-week cycle. Again, I mentioned it's a 28-day cycle or lunar cycle. It means on average, a woman is fertile, on average is fertile, or can get pregnant, let's say, 25% of the time out of every cycle, out of every month, which means that for avoiding pregnancy, they can have intercourse 75% of the time on that time, and still be safe, cheap, healthy, control of their own body, and that is what I call good medical practice for these people, because they're not involved in fooling around with the hormones or anything else. Okay. Yes. Oh, thank you very much, which I forgot, because when it's compared in the population of the subset of couples who are using NFP for whatever reason, because they can be using NFP for healthy reasons, they're totally secular, they don't believe in God or anything else, have no religious beliefs, but they just want to be healthy, and she doesn't want to be putting hormones into her body, and he doesn't want to be dealing with condoms. So for that population, is between 97 and 99% when it's used correctly, properly, and religiously, to pardon the pun, consistently. So it's equivalent to, gives you the equivalent percent, but it does require discipline, right? It does require discipline and communication, which is, by the way, it's an added benefit. Now this intercourse is not just a pleasurable thing, but it's actually an act of love where it has the consideration for the woman and the man, and it just takes it to a different level. And that's where I'm going to leave it. All right. Thanks again. And we'll have class Monday, but we will not have class Friday because I'm going to be on retreat, okay? But I'll remind you Monday anyway. We do have class Monday, but not Friday, not next Friday. Okay. Thank you for your patience. Okay, another chat. Come back. Chanel. Okay, no question. All right. Thanks a lot, and I'll be posting this soon. All right. You have a great weekend now. Thanks a lot. Okay, Chanel, I'm going to be disconnecting then. Thanks again. Okay, you're welcome. Bye-bye.